Welcome back, everybody, to part 18 of our internal medicine review questions. Another 10 questions here. If you haven't had a chance yet, please consider subscribing to my Patreon. You can get there by clicking the link in the description of the video or in the I button in the upper right-hand corner. I very much appreciate all the contributions that I can get to help offset the cost of these videos. $1 a month goes a long way. And certainly I thank all those of you who have already donated. I really appreciate it. Okay, let's go on with question 1. We got a 25-year-old woman coming into the occupational health clinic after a needle stick injury. After drawing blood from an HIV positive patient, she accidentally swiped her hand against the needle, breaking her skin. The HIV positive patient is on antiretroviral therapy and has an undetectable viral load. He has no history of viral hepatitis. The current patient, meaning our 25-year-old, has no medical conditions and takes no medications. All her immunizations are up to date. HIV testing is performed and is negative. Which of the following is the best next step in the management of this patient? A. Zidovudine alone for 4 weeks, followed by HIV testing. B. Zidovudine, lamivudine, nabacavir for 6 weeks, followed by HIV testing. C. Tenofovir, emtricitabine, and raltegravir for 4 weeks, followed by HIV testing. D. Test for HIV in 4 to 6 weeks. Or E. No further management is necessary. All right, so this is a different one. Let's go ahead and look at our answer. So this is C, tenofovir, emtricitabine, raltegravir for 4 weeks, followed by HIV testing. So what's going on here? So this is an accidental needle stick injury, or what we would call an occupational HIV exposure, which is a little bit different from how we would go about managing a community HIV exposure, such as if a patient has unprotected sex with somebody who they don't know has HIV, or maybe they do know they have HIV. It's a little bit different approach. But for this patient, it is an occupational exposure. Now, what do we know about the patient she was exposed to? Well, he or she doesn't, we don't know. But this patient was well treated on antiretrovirals and has an undetectable viral load. Now, you may have heard that this phrase, U equals U, undetectable equals untransmissible. That is for sex only. All right, that is not applicable to occupational HIV exposure. Now, is the chance substantially less that she will develop HIV? Yes. However, when it comes to post-exposure prophylaxis in the occupational setting, the fact that he has a viral load that's undetectable is irrelevant. We still must do a post-exposure prophylaxis for this patient. Now let's go ahead, so that eliminates E, and that eliminates D. So let's look at these 3 regimens. So zidovudine alone for 4 weeks. Would that be effective? Actually, it might, but there's better regimens. So that would be better than nothing, but that's wrong. So what we know is that all the time when we have a patient who's occupational HIV exposed, we do triple therapy, just like if we were treating a brand new patient with HIV. So now we look at these regimens. Well, it's actually always 4 weeks, so that would help you eliminate B. But what also helps you eliminate B? You should know a thing or two about what each of the HIV drugs, what class they fall in. So zidovudine, lamivudine, and abacavir. Those are all NRTIs. We can't use that. Why? Because with triple therapy, generally you will use 2 NRTIs, so like tenofovir, emtricitabine, zidovudine, lamivudine, and then 1 drug of a different class. So that could be a protease inhibitor, an integrase inhibitor, an NNRTI. You choose it. But it's got to be 2 NRTIs and 1 of a separate class. Okay? You cannot use 3 drugs of the same class. Tenofovir, emtricitabine, both NRTIs. Raltegravir, what drug class is that? It's got the word tegra in it. Integrase inhibitor. Integrase. They all have that. Dolutegravir, bictegravir, raltegravir, they all have that tegra in the middle of it. Okay? So For patients that we are considering post-exposure prophylaxis in the occupational setting, we need to know two things. What were they exposed to and how were they exposed? So if the part of their body that was exposed was a mucous membrane, so oral usually, non-intact skin, that's the more common one because that is going to be your needle stick, or percutaneous exposure, then the answer to that is yes, then your next question is, well, what were they exposed to? If it was blood, absolutely. Semen, absolutely. I don't think you're going to run into that too much in the occupational setting. Vaginal secretions or visible blood in a type of fluid. So that could be amniotic fluid, CSF fluid, and so forth. So the answer to, both of those have to be true. So if you just get blood on you, you just get HIV positive blood on your arm, not a problem. Okay, if you get, for instance, urine and it gets, God forbid, in your nose, not a problem. Okay, we know that urine, feces, nasal secretion, saliva, sweat, tears, you don't get HIV from those things. Okay, and we used to think a long time ago, well, what happens if you sit on a toilet seat that somebody who had AIDS was sitting on? Does that raise my risk? What if I kiss someone with AIDS? What does that do? We didn't know. And so for a long time in the 80s and even into the 90s, people with HIV and AIDS were treated like lepers. Fortunately now, not only is it rare for people to get AIDS because of antiretroviral therapy, but we know even those who do and those who have HIV, we know that they're not contagious in the same way that maybe somebody with meningitis might be contagious or somebody with COVID might be contagious, okay? Now, the timing for this patient, you are going to start post-exposure prophylaxis immediately, and you will continue for 4 weeks. Thereafter, at 6 weeks and at 4 months, you will do an HIV-1, HIV-2 antigen antibody panel. Okay, so you're going to be testing them for HIV at 6 weeks and at 4 months. The regimen we already talked about. Now the common regimen, tenofovir, emtricitabine, raltegravir. I would say that's the most common that comes up on the test. There's also dolutegravir and more recently bictegravir. The nice thing about bictegravir is that all three of these would be in one pill. So I don't know. I mean, that is a drug that we give to people who have HIV. I've never seen it given for post-exposure prophylaxis, but, in theory, all of these would work. Okay, now tenofovir, emtricitabine, what do we know about those two drugs? What are those two drugs alone used for? Pre-exposure prophylaxis, very, very common nowadays. Okay, question 2. A 63-year-old man presents to the clinic complaining of fatigue for the past month. He says that over the past 6 months, he began noticing difficulty doing his 5-mile walks, which he's done ever since he was a young adult. Then he began having difficulty keeping up with his grandkids. Now he has a hard time getting through the day without taking sitting breaks every couple hours. He's in otherwise excellent health and has no chronic medical issues. He has a glass of wine every night, but does not smoke or use recreational drugs. He takes a low-dose aspirin, but no prescription medications. He last had a colonoscopy at age 55, which was unremarkable. Vitals are within normal limits. Physical is notable for mucosal pallor. Stool guaiac is positive. Labs show the following. You can read those. Colonoscopy is performed and is as shown. I'm going to show you the picture and then we'll come back and finish this. So this was found in the ascending colon. Okay. In the general population, the cause of this patient's condition is most commonly associated with which of the following? A, chronic alcohol use, B, aortic stenosis, C, cirrhosis, D, long-term steroid use, or E, daily aspirin use. Okay, we're going to go on to the answer here. Aortic stenosis. So what did this guy have? What is this? This is an arteriovenous malformation, also known as angiodysplasia. So angiodysplasias are very common in patients over the age of 60, and they're thought to be due to chronic occlusions of the submucosal veins, which then leads to vascular congestion and then the formation of these dysplastic arteriovenous collaterals. They typically don't bleed. However, the rates of bleeding are higher in patients with a bleeding diathesis. Now, what's one of the more common diseases that cause you to bleed more that you see all the time? Von Willebrand disease. So we know that von Willebrand disease would increase your risk of bleeding through an AVM. Well, what also kind of plays a role with von Willebrand's disease is more of an acquired von Willebrand disease. Aortic stenosis. So remember, with aortic stenosis, because you've got blood moving through that crunchy vessel, it can damage those von Willebrand factor multimers. And so you essentially get an acquired von Willebrand disease. Now, in addition to the fact that you need von Willebrand disease to help you clot, there's another thing kind of going on here. And that is that von Willebrand factor modulates vascular endothelial growth factor receptors. And without the von Willebrand factor in sufficient amounts, you will actually have overactivity of those receptors. And remember, vascular endothelial growth factor, that triggers the formation of blood vessels. So it might be coming at it two ways. Okay, so aortic stenosis, von Willebrand's disease. What's the other one? End-stage renal disease. And the idea there is that you would develop a uremia, your blood urea nitrogen would go up, and that causes dysfunctional platelet aggregation. We know that that bleeding is something that people with chronic kidney disease, they do deal with, okay? So chronic alcohol use, no. Cirrhosis, along those same lines, that could cause a factor deficiency, which would raise your PT, could raise your PTT, but it wouldn't have anything to do with the platelets. Long-term steroid use, no. Daily aspirin use does mildly increase your risk of bleeding. However, it is not going to cause AVMs, okay? So it's aortic stenosis. Okay, a 45-year-old guy presents to the clinic complaining of fatigue and muscle pain for the past 3 months. He recently immigrated to the United States from Peru for a work opportunity and has been living in Chicago. He says that he eats a normal diet. He is generally healthy and has a history significant for alpha thalassemia trait. He denies sick contacts and has not been back to Peru since he arrived last year. He was seen 6 months ago, shortly after arriving, for strep throat. His BMI was 23, and today it's 29. Vitals are within normal limits. Physical exam is unremarkable. Labs show the following. TSH is 3, sed rate is 10, creatine kinase is 50. Which of the following is the best next step in the management of this patient? A, serum ferritin levels. B, anti-nuclear antibodies. C, prescribe indomethacin. D, serum 25-hydroxyvitamin D levels. Or E, repeat creatine kinase levels in 3 months. Okay, so this is kind of a complicated one. This is actually based on somebody I saw. Okay. So let's go ahead and answer this question. It is D, 25-hydroxyvitamin D levels. So this guy's got a lot going on. Let's break it down. So first of all, his complaint is fatigue and muscle pain. And he also has this weight gain that kind of stands out. I mean, 6 months to gain that much weight, to go from a 23 to a 29, that raises some alarms. So fatigue, muscle pain, weight gain, what does that make you think? Possibly hypothyroidism. You should absolutely be getting a TSH. We did. TSH is 3.0. Is that low, normal, or high? That is normal, not hypothyroidism. Okay, now what are we thinking? Well, what about this muscle pain? Maybe he's got a polymyositis. He's kind of young, but maybe. It's been going on for 3 months. Well, sed rate is 10. Is that normal? Yes, it is. So it's not polymyositis. What else do we see in this guy? Well, you should have noticed straight off the bat when we looked at these labs, his hemoglobin's 10.8. Is he anemic? Yes, he is. That's probably explaining the fatigue. Okay. And now, anytime you have a patient with anemia, you want to know what kind. So first place to go is your MCV. MCV is 77. That's low. Okay, so he's got a microcytic anemia. Is there anything in his history that points to why he might have a microcytic anemia? Yeah, alpha thal trait. Okay, that's going to cause a microcytic anemia. But why can't it be iron deficient too? Maybe he's iron deficient. Maybe it's getting worse because he's iron deficient. Well, if he had an iron deficient anemia, his red blood cell distribution would probably be high. Okay, with iron deficiency anemia, you've got some normal red blood cells and some smaller ones and some really small ones. Whereas with thalassemia, they're all kind of abnormal together. And so with thalassemia, you will tend to see a normal red blood cell distribution, but with iron deficiency, you'll have a longer distribution. And so that points away from iron deficiency. So what we see in his CBC is exactly what we would expect to see from somebody with alpha thalassemia. So it has nothing to do with his anemia. So now what is it? Well, let's look at the fact that the USMLE rarely gives you history on a patient that isn't useful for answering the question. This guy is from Peru. Okay, rarely are they going to tell you the guy's from X place and it's not going to matter. A lot of times when they're telling you a patient comes from this place, they want you to think, or they went to this place and they just came back, they want you to think, what are some things that go on there that don't go on in the US? I mean, tuberculosis, Chagas disease, you name it. However, one of the things that they could be asking here, and what they are asking here, is what might happen to an immigrant that comes to the United States. Okay, and that's something you encounter in the US, and that's why they test it. Well, what do we know about Peru? You do need to know a little bit about geography for this test, especially in the US. You need to know where Chicago is. So what we know about Peru is that it's by the equator, and these are people who tend to be darker. They're not black, but they're darker skinned. And when you have a darker skinned person that moves to Chicago, of all places, Chicago is in the northern part of the country, like New York and Boston and Seattle and Minneapolis. Well, that's a high latitude, and they get less direct sun than, let's say, a Los Angeles or a Dallas, Texas, or Miami. So because they get less direct sun and you've got darker skin, you are at risk for vitamin D deficiency. He says he eats a normal diet. Does he take a multivitamin? Apparently not. He probably should be. And so now we need to really start thinking about vitamin D deficiency. So serum ferritin, no, he's not iron deficient. Repeat creatine kinase in 3 months? No, that's not the problem here. That's not going to change. Okay, so what about anti-nuclear antibodies? That's asking you if it's a connective tissue disorder. Well, his SED rate was fine, so probably not that. So now it's between treating this like it's nothing or getting vitamin D levels. Well, just based on this patient's history, he sounds like a guy that might be deficient in vitamin D. He came here and now the problems are starting. Okay? Now, his weight gain, why do you think he's gained weight? Well, probably because he was walking a lot more in Peru, probably had a little bit healthier of a diet. I went to Peru, I guess it'll be 6 years ago now. And let me tell you, you can lose weight because they eat really healthy. You come up here, you're eating McDonald's, you're eating fast food. And even people from Europe who come to the United States will tend to gain weight because you're not taking public transportation as much. And you think, well, I can just eat the same way. Even if they're not eating fast food, they're not walking around as much, they gain weight. It happens. It happens. So we need to make sure that he's not vitamin D deficient. And that is, in fact, the most likely explanation here. So vitamin D deficiency is first and foremost associated with decreased sun exposure. Now that's not going to be someone like me, right? My ancestors, they come from Norway, Sweden, and Finland, right? So I am pale as a ghost. I need to step outside in the sun for 2 minutes and I've got all my vitamin D for the rest of the year. Not really, but you know how you don't see much vitamin D deficiency in people who are pale. This usually happens in darker skinned people. But just think of, ways that you would not get out in the sun. So if you're working night shifts, right? Where you're not spending much time outside, or maybe you're working in day shifts in a basement or something like that. Night shifts, you go home, you go to sleep during the day, and then you go back to work and it's dark out. If you're institutionalized, so if you're institutionalized, like in a prison where you might only get to go outside an hour a day, or if you're in a nursing home where you might not get to go outside at all, that could be. Dark skin pigmentation, like in this guy, advanced age kind of associates with institutionalization. Malabsorptive disorders. Remember, vitamin D, along with A, E, and K, are all fat soluble. You got cystic fibrosis, you're not absorbing your fats. You got celiac disease, the lining of your intestine is diseased. Boom, malabsorption. Obesity, for reasons I don't really know, and chronic kidney disease. Remember, in order to synthesize your own vitamin D, you got to have a functioning kidney and a functioning liver. They both hold enzymes along the way. Symptoms early on can be asymptomatic or non-specific musculoskeletal symptoms like this guy. As it progresses, osteomalacia, bone pain and weakness, and then they can actually go on to develop fractures. To diagnose this, just get your vitamin D levels, 25 hydroxyvitamin D. Don't need to know about the levels, just know that that's what you need to get. And the treatment is oral or parenteral vitamin D replacement. We want to use oral, but when would we use parenteral? Well, if it was someone with celiac disease, if it's someone with cystic fibrosis, someone who has a hard time absorbing their vitamins, then we would do parenteral. Okay, question 4. We've got a 28-year-old woman who presents to the ED complaining of dizziness and chest palpitations for the past hour. She was at her desk at her office where she works from home as a graphic designer and suddenly experienced these symptoms. This has happened twice in the past 2 years, and she brought it up to her psychiatrist who prescribed her lorazepam for panic disorder. She took the lorazepam today, but her symptoms persisted. She has a past medical history of postpartum thyroiditis 2 years ago and generalized anxiety disorder. Medications include sertraline, lorazepam, and loratadine as needed for seasonal allergies. Medications include... She does not drink alcohol, smoke, or use recreational drugs, but drinks 3 to 4 cups of coffee per day. Vitals show blood pressure 110/72, heart rate 178, respiration 16, temperature 98.6. Physical exam is significant for tachycardia. EKG is as shown. Let's take a look. So here it is. Ignore those arrows. They're insignificant. Okay, let's go back. Which of the following is most likely diagnosis in this patient? A, paroxysmal supraventricular tachycardia. B, sinus tachycardia. C, multifocal atrial tachycardia. D, atrial flutter. Or E, atrial fibrillation with rapid ventricular response. Okay. So I'll give you one more look here. And look at your answers. And now we're going to move on to a follow-up question. So you need to lock your answer in. Vagal maneuvers are attempted but are unsuccessful. Adenosine is administered and the patient's heart rate goes to 80. EKG is shown. Which of the following is most likely the underlying cause of this patient's original presentation? A, caffeine intoxication. B, psychogenic etiology. C, Wolff-Parkinson-White syndrome. D, electrolyte disturbance. Or E, surreptitious drug use. You can't answer that until I show you this. Okay, so here you go. I'm going to zoom in here on, I think this is lead 2 here on the bottom. It's not labeled though. Okay, so take a look at that morphology here, and we're going to go back. So here are your answer choices. Give you one more look, and we're going to go on to our answer. Okay, so the answer to question 4 is PSVT. How do we know this? You can make this diagnosis purely by eliminating all the other wrong answers. Okay, with sinus tachycardia, what would we see that we wouldn't see in most other tachycardias? We would see P waves, very obvious P waves. Did we see P waves here? No, we did not. We saw T waves, we saw QRS complexes, but we did not see P waves. Multifocal atrial tachycardia. Well, you know what? Let's just go ahead and look at all of these wrong answers, and you can see why they're obviously wrong. And then we'll come back and we'll talk about PSVT a little bit. So here's sinus tach, right? You see the P wave, QRS, T wave, P wave, QRS, T wave, right? Every single time. Here's a P wave, here's a P wave, here's a P wave. Yeah, you're tachycardic. I mean, this looks like 150 beats per minute or so, but you always have a P wave before the QRS. That is sinus tachycardia. Your heart is doing exactly what it's supposed to. It's just going fast. This is what your heart might look like if you're deconditioned and you're trying to run a marathon or something like that. Multifocal atrial tachycardia. You are going to see P waves. However, the P waves are all going to look a little bit different because they're originating from different parts of the heart, or the different parts of the atrium for that matter. So rather than having, let's see if I can find a normal looking P wave. This is kind of a normal looking P wave right here. But you'll have different morphologies. So look at this one. This one's kind of deflected downwards. This one's deflected downwards. This one looks a little different. So you can see they all kind of look a little different. Even these ones that are deflected downward. I mean, that's got like kind of narrow. That one's kind of wide. This one's kind of pointy. So you see all these different looking P waves. And that is pathognomonic for multifocal atrial tachycardia. Why doesn't this patient have that? I mean, we know she doesn't have it based on her EKG. But what kind of patient does this happen in? Typically, this happens in patients who have lung disease, particularly COPD, okay? So that's not in her history. Atrial flutter. So you should know this. This has the sawtooth waves, okay? This could be regular or irregular. This one in particular here is regular, but it can be either. So you get these like sawtooth waves and then your QRS, sawtooth, QRS, okay? And then atrial fibrillation. I'm sure you've all seen this before many, many times. So here you don't have a P wave at all. You just have this very low amplitude and then a QRS and then low amplitude and QRS like that. Okay? So just from that, you should be able to eliminate everything else. Now, PSVT is not a diagnosis. PSVT is a class of arrhythmias. And the two most common causes of PSVT are AV nodal reentrant tachycardia and AV reentrant tachycardia. They sound the same, but they're a little bit different. So what's going on is with AV nodal reentrant tachycardia, you have an aberrant conduction system within the AV node. So everything is coming through the AV node. But what will happen is that instead of just going like this and going down, atria up here, ventricles down here, you'll have another pathway and it'll self-propagate. And so you'll have that tachycardia from that because it just kind of propagates all on its own. Okay? So this is important that you understand this. Now, AV reentrant tachycardia means you have an accessory pathway that's outside the AV node. Okay, so yeah, you'll have this, and this will work just fine. But then you'll have somewhere else, you'll have a pathway that goes from ventricle to atria and then back down like that again. Okay, so the reentrant, the disordered area is outside the node. Okay, now all of these paroxysmal supraventricular tachycardia, or they might just call it supraventricular tachycardia. Paroxysmal just means it comes and goes. These are all narrow QRS complexes. Now, the wide QRS complexes like that could be something like VTAC. Okay, these are all narrow QRS complexes, and that's important that you know that because the treatment is going to be different. Okay, now let's talk about the answer to 5. So the answer to 5 was Wolff-Parkinson-White syndrome. How do we know? It is very, very simple. So look at this. What do you see that's abnormal? The delta wave. So normally a QRS complex, let's go back. A QRS complex is supposed to be like that. Well, this, it kind of goes like that. You get that upward inflection. So instead of going like that, you go like that. Okay, that kind of swoop that goes up. That is called a delta wave, and that is pathognomonic for Wolff-Parkinson-White syndrome all the time, every time. I don't know of any other disorder that has a delta wave. If you're a cardiologist or you know your cardiology and you're watching this, tell me if there's anything else with the delta wave. Okay, I want to know. But on the USMLE, if you see delta wave, boom, Wolff-Parkinson-White, you're done. Okay, caffeine intoxication, psychogenic etiology, those are both going to be sinus tach. Surreptitious drug use, if she's on cocaine, she's on meth, which we have no reason to believe she is, that's going to be sinus tach. Electrolyte disturbance, like a hyperkalemia, hypokalemia, those are going to cause ST and T wave changes, but it's not going to cause a delta wave, and it's probably not even going to cause a tachycardia anyway. Okay, so the answer is C. Now, I just want to point out, let's say in the future she develops these episodes again. What drug would we want to give her? You should associate this drug with Wolff-Parkinson-White, procainamide. Okay, this works great for patients with Wolff-Parkinson-White. Adenosine is fine, but procainamide is better for Wolff-Parkinson-White. Okay, so there's a little bit more about the delta wave. You can see here how they look different. And it's really a widening of the QRS. Okay, question 6. An 18-year-old woman presents to the clinic complaining of joint pain for the past 2 weeks. She says that she feels stiff when she wakes up and that her joints are painful throughout the day. She's never had this before. Around the same time her joint symptoms developed, she had a cold, which was accompanied by a fever and a rash on her face and arms. Both the cold symptoms and the rash have since resolved. She has no significant past medical history and is on no medications. She's not sexually active. She doesn't smoke, drink alcohol, or use recreational drugs. She's on prenatal vitamin. She denies any other symptoms. Vitals are within normal limits. Physical exam reveals mild symmetric swelling of the metacarpal phalangeal and proximal interphalangeal joints bilaterally. The wrist and knee joints are tender to palpation but have no swelling. Strength and range of motion are intact. Remainder of the physical exam is normal. Which of the following is the most likely diagnosis? A, viral arthritis. B, systemic JIA. C, Lyme arthritis. D, systemic lupus erythematosus. Or E, acute rheumatic fever. Okay, so let's go to our answer. Oh, I'm sorry. I have a follow-up question. Okay, so lock in your answer here, and let's do the follow-up question, then we'll talk about both of these. All right, so upon appropriate treatment, if necessary, the patient asks what her long-term prognosis is. Which of the following is the most appropriate response? These questions, by the way, step 3, classic. They love you to know prognosis. So A, you will likely have joint pain long-term, but you will experience relief with ibuprofen. B, daily medication is necessary to prevent the formation of joint deformities. C, most patients are cured with antibiotics and have no long-term problems. D, you will experience a full recovery without prescription medications. Or E, the course of your joint pain is unpredictable and you will need to follow up with a rheumatologist. Okay, so we're going to go to 6 now. Pick your answer. So the answer is viral arthritis. Okay, this is a patient who started out with flu-like symptoms. She had a rash, and then she gradually then, over the course of a small period of time, she developed joint pain. This is classic viral arthritis. You also see a very similar picture in small children who can get transient synovitis, which is a little bit different, but it kind of causes the same sort of joint pains and stuff like that. But this is viral arthritis. And the reason it's viral arthritis was that it was preceded by a viral illness, and then all of a sudden you have joint pain. Now, if she was saying, I've had joint pain for the last 4 years, then we need to be thinking about something else, maybe a lupus or something like that. But this has only just been a couple weeks. And so we know that it's probably related to what was happening a couple weeks ago. I mean, this is just common sense, okay? I know that you guys are studying a lot and you have a lot of things you're trying to cram into your brain, but one of the things I've noticed with medical students is that they kind of leave the common sense outside the door and they think, oh, well, maybe it's lupus. Do you develop lupus in 2 weeks? No, when a person comes in with lupus, they're going to say, I've been dealing with this for months. Okay? Then they're not going to say, I woke up and I think I have lupus. I've been thinking about this for a long time. It's kind of like being pregnant, right? You know, but then you wait a little bit and then you test. You don't just test every time you're a day late with your period. So this came on very quickly. Now, let's go through these wrong answer choices. Systemic JIA. Well, she's a young woman. She could get JIA. It's not just kids. Just because it says juvenile doesn't mean she can't get it. She's 18, So what would that look like? So JIA has an interesting course. They will have a daily fever for at least 2 weeks in a row. And then they have a rash with that. And the interesting thing about that rash is that it's called evanescent. Now, I knew the singer Evanescence before I went to medical school. And so I learned this word. I was like, okay. So evanescent rash. What that means is that the rash will get worse with the fever and then kind of chills back out a little bit. And so it's kind of like a glowing rash, kind of romantic, isn't it? So it comes and goes, and then that needs to be going on for at least 2 weeks. And it needs to be a fever every day. She doesn't have a fever now. Also, in order to satisfy JIA, she's also got to have the arthritis for at least 6 weeks, and she does not, and that would exclude JIA. What about Lyme arthritis? What kind of rash would you see in Lyme arthritis? Erythema migrans. I'm going to switch my pen to red. So what that would look like is something like this. Maybe you'd have it like that, or maybe it'd be like this, but it would be a target-like rash. It wouldn't be a lacy rash on both arms. And I didn't describe the rash, but this isn't going to be all over the place. You're going to have 1 or 2 or maybe 3 of them, depending on how far you are progressed. So that's out. What about lupus? She's the age that you could get lupus. She's a woman, but lupus typically has more systemic features. They may have oral ulcers. They may burn really easily in the sun. They tend to have more of that characteristic malar rash. If you do if you've got a patient that presents like that, you wouldn't know. But so you'd have to do labs, get a SED rate, get a CBC, look for maybe anemia of chronic disease, look for disturbances in the white count, maybe high, maybe low, get a complement level. That would be low. Check a urinalysis. You might see proteinuria. There's just not enough here for lupus. And then acute rheumatic fever. What does that look like as far as rashes? So as far as rashes with acute rheumatic fever, what they get is erythema marginatum. And what I like to think of with erythema marginatum is it's kind of this unusually, I don't know what you call it, polygonal, but sort of, it doesn't really have a shape. It's just kind of these, shapes like that, right? And they'll have the redness on the inside, and then they'll have an outline that kind of runs parallel to that. Just go and look up erythema marginatum, and you'll see exactly what I mean. That's not this. Okay, she's got just a rash that came on recently. This is viral arthritis. Okay, so now that you know it's viral arthritis, I'm going to switch back to black here. So now that you know it's viral arthritis, what do you tell her? So do you tell her you will likely have joint pain long term, but you will expect relief with ibuprofen? No. What's that? Well, who would you tell that to? You tell that to someone with osteoarthritis. Okay, yeah, it's going to be there forever, but you'll get some relief with NSAIDs. No. Daily medication is necessary to prevent the formation of joint deformities. Who would you tell that to? RA, rheumatoid arthritis. How about most patients are cured with antibiotics and have no long-term problems? Who would you tell that to? Septic arthritis. This patient would be febrile. She'd have it would be one, usually a large joint. It'd be swollen and red and tender and hot. How about the course of your joint pain is unpredictable and you'll need to follow up with a rheumatologist? That could be a lot of them. That could be lupus. That could be JIA. That could be RA. So that's kind of generic advice. This patient doesn't need to follow up with a rheumatologist because we know what she has and we know how to treat it, which is supportive care. All right. So this typically comes from a parvo B19 infection, but can come from any virus. But parvo B19 is the big one. Okay, so a lot of you probably hear parvo B19, you think slap face rash, child. What does this have to do with adult medicine? It has a lot to do with adult medicine. Okay, children are not small adults, but adults can be big children. That's, you hear your pediatrician say that children aren't small adults. Well, that is true, but adults can get pediatric issues too. Adults can get measles, adults can get mumps, adults can get parvo infections. Now, adults may not have the slap cheek rash, but they can. So what's going to happen with a parvo B19 infection is they're going to get a flu-like illness. They may describe that as a cold. They may describe it as a flu. They may go in, get tested for flu, and they test negative, and then the nurse tells them, you just have a cold, just ride it out, which is the correct advice, but it doesn't mean they had a rhinovirus cold or a garden variety coronavirus cold. They could have a parvo cold. So they'll have a rash. In young children, it tends to be the slap cheek rash. And in adolescents and adults, it tends to be more this lacy reticular rash. I'll show you some pictures. Okay, but it can go both ways. Okay, so this is just classic. It's not all the time. Now, there are a couple of patient populations where parvo infections can be more problematic. Number one, pregnant women. It's not going to be a problem for the woman. However, it can cause high drops and miscarriage for the fetus. Transient aplastic anemia. It can happen to anyone. That can happen to anyone. So this girl could have came in and she was tired and you drew a CBC and her hemoglobin was 9.8. Okay, that could have happened. Typically, it's not going to cause an anemia that's bad enough for any kind of transfusion or anything like that. It is just an effect. The parvovirus can affect developing blood cells. However, there are some patients who can really be affected. And those are patients who have a high red blood cell turnover. So think of sickle cell disease, think of thalassemia, think of other blood disorders like congenital spherocytosis, hereditary spherocytosis, hereditary elliptocytosis, G6PD deficiency, any kind of blood disorder where you've got higher turnover and you rely on your bone marrow to make more blood cells, make them faster. A parvovirus that slows that down can be really damaging, and that can cause what's called an aplastic crisis, okay? Diagnosis is clinical. If you really need to, for whatever reason, nail down the diagnosis objectively, there is serology. The treatment is supportive. NSAIDs as needed for the joint pain. This goes away. It is self-limited, and you don't need to do anything. The prognosis is excellent. So here's your rash. You can see kind of lacy reticular rash, kind of like what you might see on your hands if you go out on a cold day, especially me because I'm practically Casper the Friendly Ghost. I'm telling you, I go out 5 minutes in the sun and I fry to a crisp. Here's another one. So this is going to be a flat rash. You're not going to feel anything. Okay. I've even gotten into using that self-tanner. I mean, I don't want to look like Donald Trump or anything, but, it would be nice to look like I'm alive. Okay, go on to question 8. 68-year-old guy comes into the clinic complaining of fatigue for the past several weeks. He has a history of type 2 diabetes mellitus and hypertension, and he's worried that this has something to do with his heart. Medications include metformin, glipizide, and lisinopril hydrochlorothiazide. His most recent A1C was 9.1, and he's struggled with poor diabetic control for the past several years. Vitals show blood pressure 148/95, remainder within normal limits. Physical exam is unremarkable. His BMI is 30. Labs show this picture. You can look at that. Which of the following is the best next step in the management of this patient? A, serum protein electrophoresis. B, supplemental folate and B12 and recheck hemoglobin in 4 weeks. C, serum iron studies. D, darbepoetin. Or E, bone marrow biopsy. Okay, so I'll let you pause, and we're going to go to the answer. Serum iron studies. What do we know about this guy? So first of all, his underlying conditions. Poorly controlled type 2 diabetes and hypertension, which is probably not being well controlled given he's 148/95 right now. What are those two things put you at risk for? Chronic kidney disease. Okay, chronic kidney disease. Uncontrolled diabetes can lead to diabetic nephropathy. Uncontrolled hypertension, hypertensive nephropathy. His kidneys are under attack. And the labs reflect that. Creatinine of 3.0, that is very high. So this guy has chronic kidney disease. Now, in addition to that, he is anemic. He's got a hemoglobin of 9.3. an MCV of 88. Well, he's complaining of fatigue. It's probably the anemia that is behind the fatigue. Now, what kind of anemia is this? We know it's anemia, but what kind? The MCV is 88. Is that an iron deficiency anemia? Probably not. Is that a B12 folate deficiency anemia? Probably not. It is probably either anemia of chronic disease, if he's got some kind of inflammatory issue going on, which we have no reason to believe he does, or it's anemia of chronic kidney disease. What is anemia of chronic kidney disease? Anemia of chronic kidney disease is when the kidneys are no longer working sufficiently enough to make erythropoietin. Erythropoietin is a growth factor to develop red blood cells in the marrow. We all make it, but if your kidneys don't work, you can't make it. And the nice thing about that, I mean, it's terrible to have, but we have erythropoietin that we can give you. Okay, it's a recombinated erythropoietin, and we can administer that, and it takes care of that problem. Now, it's not going to take care of all the other renal problems, but it can take care of that problem. And so the drug that we give is darbepoetin. There are others, but that's one of them. They'll all end in poetin. However, we cannot give any kind of EPO analog until we rule out other causes of anemia. So you're going to need to get iron studies. You're going to need to get B12 and folate levels. Okay, you got to do all this stuff to make sure that there is nothing else going on here. Okay, get a stool guaiac. You know, when was the last time he had his colonoscopy? You got to rule out all the other causes of anemia before you give an EPO analog. Okay, so for that reason, it is C. Serum protein electrophoresis? No, that would be if we thought he had multiple myeloma. And what would his calcium be if he had multiple myeloma? It would be high, not low. Supplemental folate and B12 and recheck. He doesn't have any real risk factors for those things. He's not on a weird diet. He's not an alcoholic, so no. Darbepoetin? Well, yes, but it's premature. Bone marrow biopsy? Well, his platelets look good. His leukocytes look good. This is just a hemoglobin thing, so probably not. Remember, if it was cancer, if it was leukemia, all the lines would be off. So this is an important principle. If you need to put somebody on an EPO analog, you always, always, always do an anemia workup and rule out any other cause of anemia. Rule out iron deficiency. Rule out anemia of chronic disease. Rule out hereditary things, which I mean, this guy's 68, but rule out B12 deficiency, rule out folate, rule out everything, and then, and only then, you would give darbepoetin. One of the most and you see this all the time, one of the most common reasons somebody will get put on an EPO analog, and then they'll be like, why isn't this working? And the reason it's not working is because they were on a crap diet for a long time, because their kidneys weren't working, they weren't taking care of themselves, they were in fact iron deficient. You throw them on the EPO, well, yeah, now they're making red blood cells, but there ain't nothing in it. Okay, so you gotta make sure that their iron stores are there so that when you give them the EPO analog, they can make nice, good, juicy red blood cells. So it is serum iron studies. Okay, let's go ahead with question 9. We got a 48-year-old woman who was involved in a motorcycle collision 3 weeks ago and now presents to your clinic as a follow-up. After the accident, she underwent MRI and was found to have a herniated disc at the level of L3, L4. There was no nerve root impingement. The remainder of the injuries included mild scrapes and bruises. She did not lose consciousness during the accident. From the ED, she was discharged on naproxen, which she has had to take as often as she's allowed. Today, she says she continues to have back pain, which she rates as a +6 out of 10, and is frustrated her back pain isn't improving. She has a history of generalized anxiety disorder. She's on escitalopram and a multivitamin. She works as an office secretary. On physical exam, there is mild paraspinal tenderness at the level of L3. Normal strength, sensation, and reflexes. After counseling the patient about the nature of her pain, she says that this pain is going to make me lose my job. My dad got into a farming accident and developed back pain, and he was never the same after the accident. I'm afraid to go out anywhere, and I don't know what I'm going to do. Which of the following is the most predictive of poor long-term functional status in this patient? A, heavy use of NSAID medication. B, family history of debilitating back pain after the accident. C, localized paraspinal tenderness, D, maladaptive pain response and behaviors, or E, bulging disc on imaging. Okay, so we're going to go to the answer, and it's D. So this is a classic step 3 question where they're asking you counsel the patient on their prognosis. That is something that you run into on step 3 that you don't run into so much on step 2. Kind of one of the things that makes the test a little bit different, although for all intents and purposes, they're basically the same test. So let's just kind of look at this patient. She was in a motorcycle accident 3 weeks ago. Okay, do you think you're going to be back to 100% in 3 weeks? Absolutely not. Anytime you have an injury that's bad enough to where you end up in the hospital and you have to get imaging and they find a herniated disc and they're sending you home on pain meds, it's a pretty significant injury and you're not going to get better in 3 weeks. I mean, my dog bit my finger 2 weeks ago and it still hurts, right? So, I mean, when you get injured, things can hurt. Okay. And it goes on for some time, and we have to be realistic about that. And that is so important that when you are talking to your patients, that you let them know this is what to expect. It's not going to be better tomorrow. It might not be better next week. Maybe it'll be better next month, or maybe 3 months down the road. But it's important for them to know that, because if you tell them, well, it'll probably be better in a couple weeks, when it's probably going to take a couple months, they're going to come back in a month and they're going to be freaking out, wondering why they're not feeling better. Okay. Now, let's look at her recovery process. So she had mild scrapes and bruises. She didn't lose consciousness, but she had a herniated disc. So this was back pain. She was discharged on naproxen, and today she rates the pain as a +6 out of 10. Now, if you were in a serious accident and 3 weeks later your pain is a +6 out of 10, which +6 out of 10 is usually, most people would describe that as a really bad headache, but, pain's subjective. But +6 out of 10 is usually something that's very unpleasant, but you can live with. Okay, that's a pretty normal place to be. Again, pain is subjective, but that's a pretty normal place to be. The mild paraspinal tenderness, is that normal after a back injury? Yes. What that's telling you is you've got lumbosacral sprain. That is nothing abnormal. That's not suggestive of any kind of fracture or anything like that. Okay, so that is not a problem. The heavy use of NSAID medication, is that okay? Yeah, she can take the NSAIDs as much as she's prescribed. That's fine. Now, if she were discharged on narcotics, if she was discharged on, codeine, or certainly Norco or something like that, then absolutely that would be more of a concern. If she's taking Vicodin every 6 hours, that would be a problem. But just taking NSAIDs frequently, not a problem. Family history of debilitating back pain. Now that's where it gets interesting, but the family history actually doesn't play any role here, and we're going to talk about this. And then the bulging disc, no. The bulging disc was just part of the injury. So there are a number of prognostic factors in low back pain, and what you're going to see is a lot of them are in your head, okay? So the first couple are advanced age and poor baseline functional status. A few years ago, my grandma fell down. She broke her hip and she had to have surgery. My grandma was 96 at the time. She's still alive and kicking. She's 99. Well, maybe not kicking, but she's 99. Now, do you think she is now how she was 4 years ago? No. Now, on the other hand, if I were to break my hip, do you think I would be okay in a few years? Yeah, I would probably be back to 100%. So age plays a big role because age is about healing. The older you get, the longer it takes to heal. Poor baseline functional status, kind of along the same line. Severe self-rated pain and mood symptoms, that kind of comes down here to psychosocial factors. So really what we're talking about when we talk about psychosocial factors, this is just a really big deal when we're talking about low back pain, because low back pain is so common. It's really about your coping mechanisms, okay? If you think that your back pain is going to be the end of the world, it's probably going to bother you a lot more. If you think that your dad had back pain and he was never the same and his life went down the tubes, it's probably going to bother you more. If you think you're never going to get better, it's probably going to bother you more. Okay, so a lot of this is psychological. Now, this is kind of along the same lines of why we send patients with fibromyalgia to get cognitive behavioral therapy. It's not because the pain is all in their head. They have real pain. It's because strengthening those coping mechanisms, especially when there's a comorbid mood disorder or anxiety disorder, strengthening those coping mechanisms can really help people deal with the pain. And that's really what's most important. And then no interest in mobility or exercise. Of course, exercise, physical therapy is a part of dealing with pain. And then required opioid therapy to manage pain. That tells us other things. So remember that psychosocial factors play a big role in recovery when it comes to chronic pain. All right, we'll finish up with question 10. We got a 30-year-old guy brought to the ED by his mom after suffering a witness tonic-clonic seizure. He was diagnosed with epilepsy at age 20, and his most recent seizure was at age 22. At age 27, his neurologist gradually discontinued his anti-epileptic med, and he's been seizure-free ever since. He has a history of major depressive disorder, which is well controlled on venlafaxine. In the ED, the patient is given a loading dose of fosphenytoin and is admitted to the hospital for observation, where he was given daily phenytoin as a maintenance dose. 3 days into admission, he develops horizontal nystagmus. Phenytoin level is found to be 21. Normal therapeutic range is 10 to 20. Repeat levels are the same. Which of the following is the best next step in the management of this patient? A, discontinue phenytoin and check levels in 48 hours. B, reduce dosage of phenytoin and check levels in 48 hours. C, maintain the same dosage of phenytoin and check levels in 48 hours. D, discontinue venlafaxine, maintain the same dosage of phenytoin and check levels in 48 hours. Or E, taper phenytoin and start lamotrigine. Okay, so the answer to this one is B. So what do we have here? We got a guy who has epilepsy. As is commonly done, if you go seizure-free for X period of time, a lot of times the neurologist will want to reduce the dosage. And so they can do that, and eventually they can discontinue. Some people, they have epilepsy for a period of time, and then it goes away. Other people, they live with it their whole lives. This is done by a neurologist. You will never be expected to know when and how to do this. So what we find, though, is that he had a seizure, so now we know his epilepsy is back. Of course, you want to do, your urine drug screen and your finger stick glucose and your metabolic profile and all that stuff that you do with a patient who has a seizure, a CT of the head maybe. But this is more than likely his epilepsy rearing its head again. So we put him on phenytoin. Remember, fosphenytoin is just IV phenytoin. And he's got horizontal nystagmus. This is a well-known adverse effect of phenytoin. So he's having adverse effects. Anytime you have adverse effects of an anti-epileptic drug, your next step is to check the level. We find that the level is super therapeutic. We repeat the levels. We find it's the same. So now we need to get those phenytoin levels down. How do we do that? Do we discontinue the medication? No. We would precipitate a seizure. Do we maintain the same dosage? No. That's not going to help. Do we discontinue venlafaxine? No, venlafaxine doesn't play a role here. Do we taper the phenytoin and start a new drug? No need to. Yeah, you could taper the drug down a little bit, but why start a completely new drug when this is working for him? We just need to get that dose down, or get the levels down. And so we reduce the dose and we check the levels in 48 hours. Very simple. Now, lamotrigine was put here. Lamotrigine is an anti-epileptic drug that you might discontinue right away. Why? Because you can get Stevens-Johnson syndrome from that. In that case, you got to discontinue it right now because Stevens-Johnson syndrome will kill you. Same as if you had, an allergic reaction or something like that. But if you're just having adverse effects that can be rid of if you just get the dosage or get the levels down into a normal range, then do that. And you do that by reducing the dosage. Do not stop it altogether. Now, this patient was on venlafaxine. Does that have anything to do with epilepsy? No, not really. What is the antidepressant that we always need to consider with epilepsy? Bupropion. And what do we do with bupropion in patients with epilepsy? We never use it. Never, ever use bupropion in a patient with epilepsy, no matter what. That will be tested on your exam. And that is all we've got for this section.